Hey Kaylee. Hey Rebecca.
I was not expecting that you would actually be on, Heather.
Well, yes, I've got to lead and facilitate the meeting, so I'm
But you're on
here.
vacation.
I know, but these
Are you
things,
having fun?
we are having a lovely time. It is very humid here in Savannah. It's only 80 degrees, but it feels about 95, but it's lovely. So
I
thanks for
love
asking.
Savannah. You know who loves Savannah is Lisa Worth.
Oh, I don't think I knew that. Yeah,
Yeah,
so we're
she lived there a while.
Oh, maybe I did know that. Yeah, so we're actually at Tybee Island, which is the beach. Well, it's 2 o'clock and we only have 6 people on, so perhaps we'll give it just a little bit more time. Oh, there's Allie. Hey, Allie. Um, I
Hello, good
guess.
afternoon, everyone.
Hi, how are you?
Doing well, thank you.
Good. Yeah, I guess maybe people are on vacation. I did get an email from Mary Bethel that she's not going to be able to join us. Something has come up. She's got to attend to. Um, oh, and I am recording, just FYI, everyone. So just want to let you know that. Yeah, I guess we'll give it a few more minutes. I was hoping more folks would show. Hmm. I didn't hear from too many people that they couldn't attend. So. Okay, Rebecca just said she has got to step away. She'll be right back. That's fine. Hey, Denisa, how are you? Oh, you're muted. Hi, Dr. Welsh-Bomber. Welcome.
I can only stay for a short period, but I'm glad to be here.
Thanks for attending. Appreciate it. Just want to let everyone know that I am recording, so just a heads up. And if you can put your name and organization in the chat, that would be really helpful.
Heather, can
And
you hear me?
yes, I can. Hey, Jennifer, how are you?
I'm good. I'm actually at the ECU Health Summit, so I will try to stay on for a few minutes. And I can't, s-
Sure.
I can't put anything in the chat. It says I can't send messages because I'm not a member or something.
I
Okay.
Teams is just anyway.
Yeah.
I will make a note that you were here,
Okay.
Jenny.
Thank you.
Thank you. No worries. Hi, Dr. Caban Holt. How are you? Good to see you. Hi,
I'm doing well,
Alana.
thank you.
Thanks for joining us. I think I got an office message that you're on summer hour. So thank you for joining. Appreciate that.
Sure.
Well, I guess we'll give it like one more minute and then we're going to go ahead and roll on and we'll just get what we can get and have join us who can. I'm going to go ahead and share this poll. So can you all see that? Oh, hold on, I've got to launch it. Sorry. Can you all see that first one?
Yes.
Yes.
Okay, excellent. Thank you. And I should say I'm Heather Carter. I'm the Dementia Services Coordinator for the North Carolina Division of Aging, and this is the Coalition for Dementia Capable North Carolina. So if this is not the meeting you want to be at, we will miss you, but please feel free to log off. I'm going to launch the next poll. Okay. I should have one more poll to launch. Okay, and here's the last one. Okay, I'm gonna stop sharing. Thanks so much for taking that poll. Appreciate it. Thanks everyone for joining. And if you just hopped on, thanks so much for joining us. If you can just drop your name and organization in the chat. And I'm going to introduce our first speaker, Kaylee Weaver. Thanks so much for being willing to share with us today. Kaylee Weaver is I'm going to read her bio. Kaylee Weaver is a planner / evaluator for the North Carolina Department of Health and Human Services Division of Aging. Prior to this role, she worked as an aging specialist at the Cape Fear Area Agency on Aging. She received her BA in Recreation Therapy and MS in Applied Gerontology from the University of North Carolina at Wilmington. She also has obtained her Certified Therapeutic Recreation Specialist certification. Kaylee has worked and volunteered in various settings across the aging field, such as long-term care facilities, senior centers, a family caregiver, academic research role, etc. These experiences drive her passion for working with the older adult population and towards enhancing aging services across the lifespan in North Carolina. Without further ado, I'm going to turn it over to Kaylee. Kaylee, let me know if you are having any trouble with your slides.
Perfect. Thank you everyone for having me. My name is Kaylee Weaver, as you said. I've been with the division since about September of last year, so it's been really nice being here, and I'm excited to speak with you all today. I'm gonna be bold and try something with my presentation to present in Teams, which I haven't done this before, so we're gonna see how it goes. All right, are y'all seeing the presentation? Yes. Okay. If at any point you're not seeing the slides or things like that, let me know. I'm trying to be tech savvy today, so we're going to see how this goes. But yeah, so today I'm here to present on the Dementia Coalition Evaluation of Recommendations. To give a little background of the planning section before we get started, the planning section falls under the Division of Aging, and there's a couple of key factors that play into this. So first of all, strategic planning, and this sets the direction and includes plans that y'all might be aware of or even a part of, such as our multi-sector plan for aging or our state aging plan. We also do a lot of data and evaluation, and this provides feedback, and it could be annual things such as state or county aging profiles or monthly reports such as our monthly ARMS reimbursement report, things like that. We do a lot of monitoring, compliance, and audits to ensure standards. We are in our monitoring season currently right now. I just did a monitoring visit yesterday, or a desk review. And then we also do our information systems, security policies, and IT projects. And this is a big area that is about security and compliance. We do things such as phishing emails and preventing data breaches. And then finally, we have our disaster response. And some of you may get emails from our planning division when there's hazardous weather. That comes from our planning team. Some of the areas that I specifically focus on are our all ages, all stages multi-sector plan for aging, our state aging plan, some data requests such as surveys or evaluation efforts, and community outreach and presentations. So the purpose of the planning division is to hopefully serve as a bridge between data and decision making, and to help translate complex ideas into clarity and support and inform actions. So I'm going to walk through kind of the process to do this evaluation for the Dementia Capable Plan. We began with the brainstorming and the collaboration. I worked with Heather and the CARES team to review the plan, previous evaluations, previous tracking, and identify steps determined needed to move forward with implementing a new evaluation approach. As I mentioned, I started the division back in September, so this is also me just learning the background and the history of the Dementia Capable Plan. So I just wanted to make sure I had a firm understanding of what it was before I started, sticking my foot in things and making any changes. So I was able to give a lot of research and background into this before we're starting with the evaluation. So next we moved into our part 1 evaluation. So given I know it may be a lot to ask for updates of all the great work that everyone's doing at one time, we decided to structure into 2 separate parts. So part 1 took place between the start of the recommendation period, which is October 2024, until now in May in 2025. And so that was about the halfway point of this year's recommendation cycle. So that's why we decided to do that time frame, and we utilized Microsoft Forms as a tool for data collection. They do a really good job of collecting that data and having a live document to check back on. And in this evaluation effort, we got about 14 responses. I want to say it was closer to 17 or 18, but I put a couple of those in that were like backlogged. So I think we had 14 total responses from members of the coalition. And that evaluation closed, I believe, it was about a week and a half ago. So since then, I began to look into the evaluation and discuss, find some findings and get some updates to share with you all, which I will begin doing in the next few slides. So the first recommendation that this group chose was recommendation 2.4. And this recommendation is educate healthcare professionals about the importance of treating comorbidities, addressing injury risk, and attending to behavioral health needs among people with all stages of dementia. This recommendation highlights the importance of partnering and working with partners such as educational institutions and healthcare associations. I know some mentioned here are the community college system, medical society, nurses association, things like that. So based on the feedback I got, I'm not going to go into detail of all the progress and updates that we received, but I'm going to go over a few. So starting off, Dr. Caitlin Jones at Wake Forest initially focused on an age-friendly health system for 3 hospitals, certification for 3 hospitals, Wilkes Medical Center, Davie Medical Center, and the Lexington Medical Center. And this was taking place in the Atrium Health Wake Forest network. And also back in March, Dr. Caitlin Jones completed Project ECHO training with the University of New Mexico as the leader in this effort. Next, we're going to talk about the NC Brain Registry, NC Registry for Brain Health. They presented a symposium panel discussion at the SEA HEC conference in April on the 4 M's framework for an age-friendly healthcare system. And this model aligned entirely with the recommendation addressing what matters, mobility, function, falls, mental health, and medication. And then next, I think we also have a speaker after this. We have an audiologist speaking, so this will be a great transition later on. But the Audiology Project is continuing to educate and share. They shared that the CDC hosted a presentation about the link between hearing loss and the risk of falls and diabetes, and a lot of information was provided that is useful in tying hearing loss and falls to dementia, which I believe is what the presentation later is going to be on. CARE Yaya has been working to educate over 2,000 students across North Carolina's universities who are aspiring healthcare professionals about dementia care. The geriatric and adult specialty team shared the report with us, and they have trained a total of 3,161 direct care workers and 523 entities in dementia since October across the state. And a few other things to note I didn't include here. The NC Board of Nursing published an article in their quarterly publication that advertised the dementia-friendly communities and hospitals toolkit that UNC CARES developed for the dementia-friendly communities and hospital. And then the CARES program also has created the 5 self-paced online on-demand trainings, and that was intended for North Carolina DSS adult service social workers. So those are some progress that's been made on the recommendation 2.4 for this first halfway point. And there were also a couple of new ideas or upcoming activities on this recommendation as well that I want to highlight. So Memory and Movement Charlotte is currently piloting their Step Into Story dementia care course. Once this pilot is complete, they plan to roll it out statewide and expanding access to high quality caregiver trainings across residential care settings. This course trains professional caregivers in continuing their care retirement communities and other residential settings to understand how they develop trust with their patients in the care and use that relationship and knowledge of their lives to better recognize and predict disease progression. And then also the UNC Center for Aging and Health, in collaboration with ECU College of Nursing and UNC Pembroke, is expanding its CDP training for certified nursing assistants this spring. They're working to embed an age-friendly and dementia-inclusive content into social work in the nursing curriculum. A faculty collaboration is planned this summer to develop practical teaching strategies for this integration, and it has a focus on rural healthcare delivery. Along with this, the UNC Family Medicine Clinic will begin 4M training in April 2025 with the intent to obtain age-friendly healthcare system level 1 by April 2026. These training sessions have been developed and are being finalized. And also under development is a note template that will be utilized to clearly document the 4Ms in patient care in the electric medical model. So those are some upcoming ideas that people have shared with us. Now moving into our second recommendation, which is enhancing the training for healthcare providers on the benefits and best practices for Alzheimer's disease and related dementia detection, diagnosis, and service referrals. So this past quarter, 57 healthcare providers successfully completed two-part dementia care model training, as reported by the UNC Center for Aging and Health. 20 of these participants were trained on-site at the UNC Geriatric Clinic, 18 internal medicine residents, and 2 medical students. This training equipped participants with essential skills to enhance dementia care and improve patient outcomes, covering best practices, communication strategies, and the latest research. The modules ensured that providers can deliver information and compassionate care. Dementia Capable Cares provided a Brain Health Summit, which provided CECs for healthcare professionals. And then the North Carolina Organization of Nurse Leaders sponsored Heather to come and speak at the annual spring conference, where she was able to educate over 280 nurse leaders across the state. NC Registry for Brain Health faculty were a part of a virtual event by recent PBS series called A Matter of Mind, My Alzheimer's. While this event was aimed at the general public, not just healthcare providers, it did touch on tools to facilitate practice and improve care navigation. This aired back in early May on PBS, but it's also available online and on the PBS app. And then I also want to note that the Dementia Alliance of NC has also been sharing educational materials and resources that they hand out at CEU's conferences for primary care and neurologists. So some new ideas and upcoming activities on recommendation 3.2. So the NC Academy of Family Physicians is offering a continuing medical education on Alzheimer's and dementia during the 2025 Winter Family Physicians Weekend in December. And this will train approximately 700 family physicians and clinicians on best practices for dementia detection and diagnosis. And then also CARE Yaya is executing a grant from NIA and Johns Hopkins to train future healthcare providers, which are college students studying preclinical career fields, about dementia care. And this training is called Yaya Guide. So some progress and other recommendations in the plan that didn't fall into these categories that some people noted was that CARE Yaya is building a dementia-friendly care workforce at scale with all of their training programs and things they're offering. They now have over 5,000 North Carolina students that have gone through the program. AARP wanted to highlight that they're still focusing on the 6 pillars of brain health and they offer 30 to 60-minute workshops in the community on the topic. NC audiologists can help educate and collaborate with medical professionals across the state to ensure proper services are available for patients in the home and in facilities. And then there's also been this dissemination of videos, outreach, and material toolkits prepared by CARES for the Division of Aging. And the NC Coalition on Aging also continues to share resources in their newsletters and invite appropriate individuals to speak at select monthly meetings. So now before we open up for some comments, questions, I do want to talk about what we're looking for as we move forward on these progress, or as we progress on the recommendations. So for the second half of our eval period, which is going to be from May to October of next year, or maybe end of September, September 30th, I would assume. We'll have ongoing efforts for recommendation 2.4 and 3.2. 2.4 being ongoing efforts to educate healthcare professionals on comorbidities, injury risk, and behavioral health in dementia care. And recommendation 3.2, enhancing training on detection, diagnosis, and best practices for Alzheimer's and related dementias through CME courses, self-paced modules, and community awareness initiatives. I do want to note that we received a lot of responses indicating the same response for both recommendations. Given that education and training are the pillars behind both of these, it makes sense that this was done. But without further knowledge of exactly what trainings and educations are entailing, it's difficult to be able to sort out which recommendations fall under which if we want to differentiate them further. So that's something to keep in mind as we move forward. We do want to ensure that we're giving attention to both recommendations and that they're both getting the evaluation that they need. So when we're moving forward, when we're completing these, try to include as much detail as possible and provide as much difference, if there is any, between the two when you're applying to the formal evaluation. So upcoming in October or November of this year, another email will be coming from Heather asking for updates to wrap up the 2025 evaluation period. It's important to note that if it's not brought to our attention, we can't know all the great things that are being done. And I know there's so many organizations on this collaboration. So we do want to highlight as much as we can of what everyone is doing. So please continue to keep up with any progress to share that in October and November. Or in the meantime, if you want to share that with Heather or myself, we'll make sure to keep note of that. And I do want to open up the floor for any feedback to the upcoming evaluation period, given the evaluation that was done previously. Were there things that you liked, didn't like? Were you able to take the evaluation? Would you need some, I can go through forms to give a more formal overview of how to utilize the system. I just want to make sure it's accessible for everyone in the group because we want to make sure we have responses from as many people as possible in the next evaluation period.
Thanks, Kaylee. I was able to log on and enter information. Did anyone on the call have any difficulty doing that? Well, that's good to see
Yeah.
and hear.
Absolutely. I'm glad it was accessible for most people, if not all people. And if anyone's privately email me if they have issues, I'm happy to provide any feedback. My email here, my cell phone's here in the on the slide, and I can put it in the chat as well. And if anyone has any updates they'd like to provide now that we're on the call that they maybe forgot to do or didn't have time to in the previous period, please don't hesitate to let me know. I can make note of that and keep that up to date.
Did anyone have anything else they wanted to share that they were doing to meet these two recommendations? Okay, well, thanks so much for your time, Kaylee. Appreciate it. And if anyone has questions, I think, Kaylee, you said you put your email address in the chat.
Yeah.
And
Well, kind
thank
of did. I
you.
just put it in there. Yeah.
That's great. And I'll be sending out the slide deck as well as the recording and the minutes from today.
Absolutely.
so-
And I just want to encourage everyone again when that email comes out. And I know right now is a very busy time, with it being, closer as we're getting towards the end of our fiscal year, things like that. So much is going on. So I just want to highlight when we get to the November, October timeline of when this form comes out again, we do really rely on your responses to let us know what you guys are doing. So that way we can really show all the great things that North Carolina is doing in the dementia and brain health realm.
Thanks,
Really?
Kaylee. Appreciate your time.
Yeah, it was great, Kaylee. This is Kathy Welsh-Bomer at Duke. We're getting ready to do our next newsletter for the registry, and then they basically, go out regularly. And I would just say that if anybody here has any upcoming events regarding brain health, dementia care, whatever, for the public to attend, just email us because we'd love to include events so that folks out in the community, particularly rural communities, know about what's going on and have access. So I just wanted to mention that.
Thank you, Dr. Welsh-Balmer. And do you mind just putting your email address in the chat if anybody has anything that they want to share with you?
That would be great. Yep, doing it now.
Thank you. And I'm sorry I'm off camera, but since I am remote in Georgia, I'm using a MiFi, so I can't see the slides and also participate. So anyway, thanks for your understanding. I have the pleasure of introducing Angela Bright Pearson. Did I get that right?
Yes.
Okay. She is a board certified doctor of audiology and a speech language pathologist. Dr. Angela Bright Pearson has childhood hearing loss and received her first hearing aid at age 16. It made such a difference for her that she wanted to become an audiologist to help others as she was helped. She understands firsthand the anguish hearing loss can cause and also what a difference her hearing aids continue to make today. Dr. Bright Pearson was one of the first in the country to receive her Doctor of Audiology degree in 2000 from the University of Florida. Prior to that, she received her master's degree in audiology and speech pathology from UNC Greensboro. She has taught at UNC Greensboro and UNC Chapel Hill, served on state audiology boards, and is presented and published on a national level. She was featured on the cover of Advance for Audiologists in 2009 for her leadership as a female practice owner and audiologist. She is certified by the American Board of Audiology, the highest level of certification available for audiologists. She is also certified in tinnitus, I think I got that right, retraining therapy, a research treatment for tinnitus, an additional specialty area in auditory processing. She has earned the trust of local physicians and praises from patients. Dr. Bright Pearson prides herself by staying on top of changing trends in both patient care and audiology technology, but also keeping family budgets in mind. Dr. Bright Pearson has been operating her business since 1996, returning to Sanford after having worked in a variety of settings as a speech pathologist and audiologist. Dr. Bright Pearson is a native of Sanford and resides there with her husband and daughter. They enjoy camping, traveling, especially to the beach, and water skiing. She is a member of Asbury United Methodist Church, where she is a pianist. She has been in practice for the last 27 years. Thank you, Dr. Bright Pearson, for joining us today, and I'm going to turn it over to you. Do you need me to advance your slides?
If I can share them here.
Yes, there is a share button right next to the leave button. It's the black rectangle with an upward arrow. And then you should be able to select whichever screen or view you want to share. And thank you for being willing to deal with this technology. If you can't, that's fine. I will share my screen.
Okay, let me bring up my PowerPoints a second and see. Hold on just a second.
Okay, take your time. We're running ahead of schedule, so we're fine. Thanks, Dr. Welsh-Balmer, for joining us.
Can you see my slides now?
No. So if you share, and you have to have the PowerPoint open.
I do. So
Okay. And thanks for taking time away from your clinical work to be here today.
okay, so if you would like to show the slides, then I will
Sure.
just talk. How about that?
Okay, and I'm not going to be able to see anybody, so if people raise their hands, hang on one
Okay.
second. Let me share my screen. Can you all see my screen?
Yeah.
Yes. Okay, thank you. And I'll start
Okay.
from the beginning.
Okay, so what we're going to be talking about today is how hearing loss is related to cognition. And you can go on to the next slide, but she did a pretty good job of introducing me. A lot of people do not know what an audiologist is, unfortunately, but we are the folks that are university trained to diagnose and treat hearing issues, balance issues, and whether you say tinnitus or tinnitus is fine. It's potato, but that is simply noises or ringing in the ears or head. So we have been in the community for a while. We try to support our community through sponsoring our local Senior Olympics. And just last month, I spoke to the Dementia Alliance of North Carolina. That's the second time in a few years I've spoken with them. Great organization. I'm sure you're familiar with them. Okay. Okay. All right, so today I'm giving a brief overview of how we hear, just so you understand a little bit more about how hearing loss affects cognition, what happens when people do not treat their hearing loss, what happens when they do, and then how we tell the difference between hearing loss and dementia. Okay. So how we hear is basically our outer ear. Its job is just to collect those sound waves and funnel them down the ear canal. They strike the eardrum that makes the bones of the ear push in and out. So that's all the middle ear. And then that snail-shaped structure you see there is the inner ear, and that is the organ of hearing. So next. And inside that little snail-shaped structure, you can see all those little black lines. Those are sensory hairs. And our inner ear is arranged like a piano from treble rolling into the bass. And so when that eardrum pushes in, it makes the bones of the ear push in. It makes all those little hairs vibrate, and that sends sounds up the hearing nerve into the brain, and that's how we process what we've heard. Next. So as I said, our inner ear is kind of arranged like a piano, going from the treble there in the blue, rolling into the bass you see in the green in the very tip. Next. And so in our brain, we have that same representation of all of those pitches. It's a little piano sitting there waiting to encode or figure out what's come up to it and make sense of it. And it's called the primary auditory cortex. Next. So there are lots and lots of neurons or nerve fibers that are going from the inner ear to the brain. And so with someone with normal hearing, there is no problem with that sound getting from the ear up to the brain and quickly and easily understanding what is being said. Next. So causes of hearing loss, we think about that, oh, it's just an old age thing, and that's really not true. We start to lose those little hairs actually the day we're born. So it is a slow process, but noise exposure is probably the biggest enemy of hearing. Noise, the impact of noise makes those bones push in so hard it breaks the hairs, and then we lose those connections going up to the brain. What's important for our community to know, our medical community, is that a lot of the medical conditions that folks have, like diabetes, a heart condition, thyroid issues, kidney disease, hypertension, high cholesterol, smoking, those all affect hearing, because that little inner ear, if you look at our pinky finger, the end of it is only about the size of a dime. So the blood vessels that go to that inner ear are the tiniest in the body. So anything that affects our circulation is going to affect our hearing. Also, certain medications, like chemotherapy, can affect hearing. So our ears are not just these things that sit on the side of our heads. They're very intertwined with our other body systems and our overall health. Next. So now I'm showing you a picture of an inner ear that's not so normal. You can see over on the right, there's a loss of those little black hairs, and that would be a damaged ear. Maybe someone that has had a lot of noise exposure or someone that's had chemotherapy, they've lost some of those high frequencies, and so they've lost the ability to understand speech. There's no connection with nerve fibers, that information going up to the brain. Next. So when our brain is not getting that information, it's not hearing the difference between the k and the p and the very soft sounds. Someone may not be able to understand the difference between words. So they'll say, well, I can hear, but I don't understand. So they would not be able to tell the difference between cat, pat, fat, sat, mat. So then people start to work harder. They start looking at faces and pretending to hear, and they have more difficulty hearing in background noise. So at first, they don't really realize that the brain is reorganizing, and that's what happens in the early stages of hearing loss. Next. So a long time ago, I lived in Greensboro and I worked in Winston-Salem, and there was all of a sudden a standstill in traffic. And I turned on the radio and it said a truck of frogs had turned over on I-40 and that the police were trying to round them up. And so I just couldn't wait to get home that day because I could just picture these police running around trying to grab these frogs. And I thought, well, maybe it was an exhibit at the Ashboro Zoo. Couldn't quite figure it out. And when I got home and watched the news, it was a truck of hogs that had turned over. So that's an example of hearing but not quite understanding. But that is what happens for people with hearing loss. They get a lot of the message, but if they miss that one word, then it throws off the whole sentence. And also it results in arguments with family members. I told you that such and such. No, you didn't, because that person never heard it in the first place, or they heard the information incorrectly. Next. So every time we lose our little hair cells down in that inner ear, we lose thousands of neurons or neural connections to the brain. Next. So when we think about our brain, all of those different colored areas are different parts of the brain for different functions. The yellow area is our temporal lobe, and that's where we process and understand speech. And I'm specifically pointing out the green area in the back. That's where we get our visual information. And the red area in the front is our thinking and our memory and our reasoning. Next. So if our hearing loss causes that loss of information between the ear and the brain, what parts of the brain are we using to hear, and how are we compensating for hearing loss? Next. So when we're straining to hear, if you think about someone that is not really hearing well, they are probably looking intently at you because they are reading your lips and they're trying to fill in all of the missing pieces. Remember, they're not hearing the individual sounds, so they're trying to just get the gist or the big picture. So when they're using their eyes to get more information, that's stimulating the back of the brain. And then when they're having to think about what they heard, so if someone says, I cannot find my car leaves, well, then they have to think about it. Car leaves. Oh, car keys. So they're using their memory center to make use of it. So then the front of their brain is also working. So then their brain is not being used in that normal way. So if someone with normal hearing would only be using the left side of the brain, but someone with hearing loss is using that side of the brain, the front and the back, so that then the brain starts to reorganize. Next. So it's like we're working so hard that we're driving 65 miles an hour in a 30-mile-per-hour zone. So we are using what's called increased listening effort, and we're having to work harder to hear. We're having to focus on the speaker. So at home, for example, someone with normal hearing, for example, a mom that gets home from work, she's helping the kids do their homework. There might be a video playing on the TV or music. She might be looking at YouTube for a recipe. She's answering back and forth, whereas someone with hearing loss would not be able to do all of that at the same time. They can't multitask. They have to just focus on one speaker at a time. Next. So I attended a meeting out in Colorado a couple of months ago, right before the other dementia meeting that I gave this information to. This is a researcher, Dr. Anu Sharma, and so she showed us some actual brain scans that I wanted to share with you. Next. So she was showing that the brain does reorganize after sensory deprivation. And so you can see there on the left that the side of the brain is lighting up with that red area. And over on the right, the front of the brain, the frontal activation is lighting up in a brain scan of people with hearing loss. They're using the front of the brain more to understand speech than they are the auditory cortex on the side. And the way she obtained this is not an MRI or a CAT scan. She put a cap on people with multiple electrodes and she's measuring brain activity. That's what you're seeing. Next. So as we talked about, the strain on the brain results in decreased cognitive reserve. When we're using the brain to try to hear, then there's less left for the other things that it needs to do. So over time, when we're borrowing from the memory center, that is why hearing loss is linked to cognitive decline. So we never say, oh, you have hearing loss, you're going to get dementia. It's not that type of connection, but there is a link. Next. So as I said, when you cannot hear well, you always have to be on, you're concentrating, using your vision. There was a story that she told where they interviewed an author with hearing loss about a book she had written. And when they asked her the name of the book, she couldn't remember it. And it was because she was using too much of her cognitive reserve. So that was just one example. And she had written the book, so that was pretty profound. Next. So even with early stage hearing loss, where people are having to look or pay more attention. She is showing there's already evidence of the brain rewiring itself. Often these folks with mild losses say, oh, I'm getting by. I'm not going to get hearing aids till I have to. But their brain is already reorganizing because they're compensating for their hearing loss, like we talked about. Next. The other reason that hearing loss is linked to cognitive decline is because it's very isolating. There was a lady that I just saw just yesterday that talked about how she dreaded her family gatherings. People come in all the time saying, I don't go to church anymore because I just can't hear. It's embarrassing. But when they are at home and they're isolated, or when they are in that situation, and then what you'll see oftentimes is that they're sitting back and the conversation's occurring around them. Well, then they're not intellectually engaged in the conversation. They can't converse and take part in the conversation like someone with normal hearing would. Next. And so it's too difficult for them to hear, so they just avoid those situations. So Helen Keller, who you probably have heard of, that was deaf and blind, said that blindness separates you from things, deafness separates you from people. So there's that lack of verbal exchange, the stimulating conversation. This can lead to withdrawal from those situations and then depression. It's also linked to inflammation in the brain. This is according to Dr. Sharma, so I found this interesting. And that inflammation is what turns on the genes that are related to dementia. So that is why it's so important, that we have all these wonderful senior centers, and, that's why everyone says, oh, it's so important to stay active. That's kind of the physiological reason. We want to avoid that isolation. And so I thought that was very interesting. Next. Other changes to the brain, it's just like muscles. If we don't use them, we lose them. So I'll show you a picture of that next. There can actually be shrinkage of the brain when it is not used the way that it's supposed to. So on the left there is a brain with hearing loss, and on the right is a brain with normal hearing. I do not have a lot of information on this slide. I don't know how much loss this is, what period of time, but that is something else that can occur. Next. There's been a lot of information written on the last 10 years about the link between hearing loss and cognitive decline. Next. So the study that we refer to a lot was a huge study done at Johns Hopkins, where they looked at what is normal aging, and they looked at a lot of different things. But what they saw is folks with hearing loss have poor cognitive functioning on nonverbal tests, even not necessarily verbal tests, but even nonverbal tests. And that depending on the amount of hearing loss they have, even a mild hearing loss, someone with a mild hearing loss was twice as likely to be at increased risk for developing dementia or some cognitive decline. And the worse the hearing loss got, that equated to increased risk. Next. And that's showing that there, that the worse the hearing loss is, the more profound the impact. So if you think about someone with mild loss, they might be able to get by in the conversation. Moderate means they really have to be looking at you and really focusing on you. And someone with severe hearing loss is not going to hear you unless you're shouting at them. So that's the different categories. Next. So hearing loss is a medical condition. folks come in and say, well, I have some hearing loss, but that's normal for my age. And that's not true. When you look at all of this brain research, we don't want our brain rewiring. So it's like any other medical condition. We want to catch it early and treat it early. Unfortunately, it takes the average person 7 years to get their first hearing test from the time they think they have some issues with hearing. And that's really unfortunate, because if any of us have blurry vision, we're not going to wait 7 years. We're going to get on into the eye doctor. But there's that stigma around hearing loss that keeps people from getting tested. The longer folks put off treatment, the more the brain forgets what speech sounds like. And then their prognosis for improvement with hearing aids is not as good once they do come in. And someone mentioned expense as well. So fortunately, some insurance companies are now having plans, discount plans that are related, or we're seeing more benefits. Certainly seeing a lot more of that than we had even when I started off in practice. Next. So if we know the brain reorganizes with hearing loss, does it reorganize after a person is fit with hearing aids? And so her most recent research indicates that that's what happened. So they did MRIs, or did that brain electrical activity study before and after they were fit with prescription hearing aids, and wore them for 6 months. And they did see that reversal. So that being said, it does determine, that is based on how someone wears the hearing aids. They need to be fit correctly, and they need to be wearing them consistently, not just an hour a day. And that's why one person may do have, a better outcome than another. Next. So when we say program to prescriptions, this is how that's done. A little microphone is placed in the ear along with the hearing aid. The person is sitting in front of what we call a real ear measurement system, and then we're able to measure the output of the hearing aid and give them the volume they're needing for soft, medium, and loud sounds. Next. So on the left, you'll see a green, pink, and blue lines that look like they're connecting the dots. That's where someone's hearing aid is appropriately meeting the prescription, and their brain is getting all of the information it needs, actually in the left ear and the right ear. Next. And this is an example of someone that may come in and they're not doing well with their hearing aids, and when we run the measurements, that dark line is falling way below the targets, those little purple crosses. So oftentimes we can reprogram their hearing aids, and then they'll have a better outcome. But that's really the sauce, the secret sauce, because if the aids are not fit correctly, the brain is not going to get the input and the information that it's needing. Next. So after 6 months of hearing aid use, a complete reversal of the brain patterns was noted. They also did some cognitive testing. Their listening and noise improved, and there was a trend of decreased depression. And I thought, wow, that's amazing after just 6 months. So that was awesome. Next. So this was the visual of her study. So she also looked at before the hearing aid over on the left. It showed that they were using more of the front of the brain, and then after the hearing aid, again, just the side is lighting up. And then again, somatosensory, which is multiple senses before the hearing aid, you can see a lot of area lighting up, and after the hearing aid, a much smaller area. So again, it reversed after 6 months. Next. So her summary was that hearing aids that are well fitted to target using audiology best practices and are worn for a significant duration per day show excellent brain and neurocognitive and self-perceived outcomes in adults with hearing loss. Next. There have been other studies as well that have shown that hearing aid use results in improvement and in cognitive function. So a study out of Texas showed that even after 2 weeks, they were able to attend better, had better memory recall and processing speed. Next. There's another study. There's several of these studies, and you have the slides, I think, but another study almost 10 years ago now that showed improved performance on the mini mental state exam. Next. And so treating hearing loss can reduce the risk of developing cognitive decline. And you can go ahead and advance that. In another study, after folks received a cochlear implant, which is different than a hearing aid, they also showed improvement with their cognitive scores, and that was after 1 year. Next. Overall, I don't know if you've been around someone that's before and after with a hearing aid, but we see that all of the time. Sometimes they're like different people. They come in with not a lot to say. Once they can hear, they're more interactive, and they come back and say that their relationships have improved. They feel better about themselves and have a better quality of life. Next. Dr. Doraiswamy, who I believe is a neurologist at Duke. This is his quote, that the benefits of correcting hearing loss on cognition are twice as large as using any of the cognitive enhancing drugs on the market. It should be the first thing that we focus on. Next. And so what he also says, as in that last paragraph, is that doctors should really be focusing on hearing. Anytime we suspect cognitive issues, it should be the first thing that we look at. And also I'll talk about vision problems as well. I don't know if this is in another slide, but especially we see a lot of folks that come in with macular degeneration, glaucoma. So then when they have a vision problem and a hearing problem, that's a dual sensory impairment. So their brain is even more compromised, and that's an even larger increase for cognitive decline. So we really need to get them to improve their vision and their hearing as much as possible. Next. So some of you may be familiar with, but the Lancet General, this has been a while now, 2017, identified the treatment of hearing loss as the single most modifiable risk factor for the prevention of dementia in midlife. We can't change our genes at birth, but treating your hearing loss is something that people can do. Like I said, I think that there's a lot of work that needs to be done in terms of just making people aware of that. Next. These are some other things that you as health professionals may be aware of. As healthy as we can be, the better. Increasing physical activity, again, our social contact, and just our overall health. Those are all things that reduce dementia risk. But again, treating the hearing loss was found to have the number one impact. Next. And that's just, what do you do? Medicare and insurances typically pay for a hearing evaluation, especially when it's the first evaluation to see if someone has a hearing loss. And really, that should be done at age 50. You know, we think about having our colonoscopy at age 50, but the doctors never recommend, oh, go get your hearing tested. So there's the ears and rears philosophy that you really need to get both tested. And then if someone has a hearing loss, it's not just about fitting hearing aids. They may need something to hear the TV as well. We talk to the family about communication strategies. Sometimes we'll have them do listening training. So it's more of a treatment plan versus just a device. Next. So the last thing I wanted to talk about is how it's easy to confuse dementia with hearing loss. As you look at that list, they have the exact same or similar characteristics. And so I have had patients come in that the family was told the patient has dementia. And after we tested them and realized they had significant hearing loss and fit them with hearing aids, they seemed a little bit sharper then. Well, it was because they really were not hearing what was going on around them. So then they weren't really interacting. And so it's kind of a vicious cycle. So I think we have to be careful not to assume that, especially when folks land in the nursing homes, the hospitals the first time, just because they're not responding, we can't assume, well, they have dementia, especially if the family members are not telling you that. There was another story where a lady was told that her mom had dementia when the lady, surely knew her mother did not. And when the nursing home staff brought her in, they said, see, she's laying there talking to herself. And the daughter said, she's having a conversation with someone through her Bluetooth hearing aids over the phone. So sometimes it's a lack of awareness in nursing homes and facilities about, how hearing loss can look. So I think this is a big message as well to get out to nursing homes and different places that deal with older folks. Next. So differential diagnosis of these folks is very important because that's going to determine what's the next step for them. So if they have untreated hearing loss and they simply require rehabilitation, that's one thing. They may have some hearing loss and they may have a mild cognitive impairment. And then they need to be referred back to their primary physician because sometimes mild cognitive impairment can be addressed through medical corrections. And sometimes they have significant issues with hearing and cognitive issues, even when they are using hearing aids. But if someone has dementia, it's even more important that they're using hearing devices. So it's really important to distinguish which category that they're in. Next. So I know that was a lot of information. I hope that was helpful and that it was what you needed. So I am available to answer some questions. I hope I didn't run over time there.
Yeah, you did perfect. I actually have a few questions, very informative.
Okay.
I really appreciated the visuals that you shared showing the hairs in the inner ear and how when those are destroyed, people experience hearing loss. And I assume that there isn't a way for those to regenerate. Otherwise, people would not have hearing loss. So it's not like hair on your body or hair on your head. Is that
That's correct. There's
Okay.
research. They're trying that, several years ago I said it's not going to be in our lifetime, but maybe they will one day, but that's not the case right now.
And then I know you mentioned some medications can cause hearing loss. Are they the medications that would be used for those chronic illnesses or conditions that you also indicated, or are they different? I thought I'd heard antibiotics maybe.
So antibiotics, like gentamicin, vancomycin, if they're given in the hospital through an IV,
Yes.
that's what we see.
Okay.
Some of the chemotherapies, not all of them, maybe the older ones where they figured it out and so they've switched medications. I've seen some of the antidepressants even affect hearing. Um, sometimes we've all seen the patients with polypharmacy, like they're
Mm-hmm.
on 15 different medications. So I think the more medications, the more cumulative, side effects they could have. Um, it's really hit and miss through, you know, I don't want to really name certain medications because it
Mm-hmm.
may be a side effect for one person and not another. But when I test folks, I always say, please ask your pharmacist before you start on any new medication, just to make sure that doesn't have any effects for hearing loss or tinnitus.
Okay, great. And thank you. That was very helpful. Can you explain a little bit how the cochlear implant is different from a hearing aid?
Sure. So, as we saw in that picture, someone that can use a hearing aid has enough of those hairs and neural fibers left for that sound to get from the ear up to the brain. But someone with a more severe hearing loss doesn't have enough. If you think about a little tightrope, maybe that, I don't know, a little squirrel is going to scamper up. If there's not enough fibers in that tightrope, for the gymnast to get across, there's just no
Mm-hmm.
way for that sound to get from the inner ear up to the brain. So they'll go in and they'll put in a little electrode about an inch long, and they feed it into that inner ear, that little snail-shaped structure, all the way to the tip. And so the implant microphone picks up the sound and it sends it through the head to the implant. And then it electrically stimulates the hearing nerve, and that sound travels to the brain.
And just a follow-up question. I'm sorry, I'm monopolizing, but this is very fascinating to me. The people who are born with hearing loss, do they not have the hairs in their inner ear? Is that what causes it?
Most of the time, that's what it is. It's a malformation of the inner ear. Something happened during the birth process.
Okay.
So the earlier we can detect these babies with hearing loss, and get them implanted if they're just truly deaf, the better chance they'll have of still developing normal speech and language and being able to go to school in a mainstream classroom if they're
Okay.
detected early.
Wonderful. And then my last question, I promise, is about the over-the-counter hearing aids. What
Mhm.
is your take on those? Do do they work? I mean,
So, my experience, I don't know about all the people that may be out there that are using them successfully, but I've had a fair number of people that have come in that have not been successful with them. So, typically, it's a one size fits some type of a tip. So, you've got to figure out, how to get it in your ear. There may be a button that you push to choose one or two or three settings. Maybe you program it with your phone and pick which one you like. But Dr. Sharma also did some research to see if the brain reorganized correctly with the over-the-counter aids, and it did not, because they were not meeting the correct prescription. They were not getting the sound to the brain. So, and sometimes they're really not any less expensive than some of the lower cost aids in the offices. So I think that's kind of a decision, folks have to make which route that, they want to go.
So
It's
could someone go ahead?
touted,
I'm sorry.
kind of been touted as like reading readers,
Okay.
or a beginning hearing aid for folks. But I just think, it's really not the same thing after hearing her presentation.
So it's not the same as let's say you go to an eye doctor, he or she gives you a prescription and you can go to any variety of places to get that prescription filled. It's
Yeah,
not
that's
done
correct.
the same as it
It's not
is
a
with
prescription at
over-the-counter.
all.
Okay.
Not a prescription at all.
And we've got a comment in the chat from Jennifer Shore. So okay, she said that she does not regret getting her hearing aids and they do make a huge difference. Thanks for sharing that, Jennifer.
That's great. I'm glad you've had a good experience with that. And people with hearing loss also don't realize how tired they may be at the end of the day after having to use so much energy to hear and do their job and socialize. Until I point that out, and they said, "Oh yeah." So that's another side effect of hearing loss is just the fatigue. So I'm not sure if you've experienced that, Jennifer, but I'm glad you've had a good outcome.
Kaylee's got a question. Oh, sorry. Go ahead, Jennifer.
I'm just sorry. I was just sorry, Kaylee. I didn't see your hand until I looked up. So I actually had a professor in my graduate school that had hearing aids, and she brought it to my attention that I could not. She said, "You're not hearing the words correctly, in the auditorium or in speech in seminars." And so I went and got tested. I had moderate hearing loss, and so the audiologist really, because it takes some transition time, you really have to get used to being able to hear things again and how loud things are. And so it takes that partnership with the audiologist to talk about, okay, this I can't handle because it's too loud and I'm still not quite hearing this. And so it takes a back and forth, but I've had mine over a year now and they make a huge difference. Huge difference.
Right.
I'm on mute. Go ahead, Kaylee. Sorry.
No, you're good. I just want to speak on like my grandfather. He's had hearing loss for years now. He also has Parkinson's, and so it's another added thing to it. But what's interesting with him is he's had hearing aids for a while, but he's recently loved using AirPods, like the Apple AirPods hearing function, which I thought is really interesting because he says sometimes it helps drown out some of the outside noise that he picks up with the hearing aids. And so I would just love to know if you have any experience of people using those. And I'm sure it's not as good as actual hearing aid, but for whatever reason, it works for him and he enjoys it.
They're pretty new, and so I don't have a lot of experience and I haven't seen any research around them or anything. But sometimes before people get hearing aids, they'll use their Bluetooth listening headset and they'll actually use their microphone on the phone and point it at people. And they say even doing that, makes a difference. So with Parkinson's, that's difficult. And this just is kind of a segue just for a quick comment. But, sometimes the challenge with folks with dementia and hearing aids, especially in facilities, is that they get lost. So there are hearing aids now that can stay in the ear. It's called the Lyric. It's just a little soft, yellow, spongy device. We put them in their ears and they stay in place for about 6 or 7 weeks. And the families don't have to do anything. The staff doesn't have to do anything. It is a more expensive option, but that is an option for people if they can't get the hearing aids in and out, change batteries or put them in the charger, keep up with them. That has worked very well for several of my patients with dementia.
That's excellent. Having been a long-term care social worker, I cannot tell you how many hearing aids and pairs of dentures I had in my desk trying to return them to the proper resident. So yes, that would be wonderful. Does anyone, oh, and Casey put in the chat that she really felt your comment was very insightful about getting your vision checked. If you feel like you've got blurry vision, versus people's apparent
Well,
hesitation to get their hearing checked.
I think having clearer vision helps people hear because they can also then focus better on your face. So if anyone has any questions for me outside of this, I did put my email. I don't know though if they still have the slides, but it's Dr. Bright Pearson at brightaudiology.com. So feel free to email me if you have any questions or if I can help outside the meeting.
Thanks so much. And I'm going to share your slide deck. Jessalyn, did you have a question?
No, I'll just email her. I'll just
Okay.
wait and email
Okay.
her. Thanks.
Thank you. Thanks so much, Dr. Bright Pearson. That was excellent. Anybody have any questions for her before she hops off? Thank you so much.
I thank you for the invitation and thank you for everything all of you folks are doing for people in North Carolina. Have a good afternoon.
Thanks. You do the same. Excellent presentation. Take good care.
Thank you. Bye-bye.
Bye-bye. Well, it looks like we lost a few people, but that's okay. Anybody have anything to share? I thought you were coming off of mute, Allie, and I'm sorry, I just kept rolling with my questions. No? Okay.
No, all set.
Anybody else have anything to share? Otherwise, I can give you back a whole 15 minutes of your life. All right. Well, thanks so much. And the slides will be coming out as well as the meeting recording and the minutes. So thanks so much. And we'll be in touch. We'll see you on August 20th for a wonderful presentation about Down syndrome and Alzheimer's disease. Thanks a lot, everyone. Take care.
Enjoy your vacation, Heather.
Thanks. Bye-bye.
Enjoy.